Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I'm pleased to welcome you to the multimedia summary for the journal's August 2021 issue. There are 3 articles that have been selected as our editor's choice of highlights articles this month. Our editor's choice this month is an original article that examines the occurrence of pulmonary embolism in pregnancy and the puerperium. It is entitled Acute Pulmonary Embolism During Pregnancy and the Puerperium, National Trends and In-Hospital Outcomes. It is authored by Dr. Islam El-Gandhi from Weill Cornell Medicine, Qatar, Doha, Qatar, and colleagues from several national universities and medical centers. Normal pregnancy is characterized by adaptive hemodynamic changes that promote the blood supply and physiologic development of the uteroplacental unit and the fetus it nourishes. These adaptive changes include increased plasma volume, blood volume, heart rate, and cardiac output, along with systemic and regional vasodilation. Such a hyperdynamic, hypoperfused, and vasodilated state, however, carries the risk of marked hemorrhage if blood vessels are breached for whatever reason, or when a circulatory breach is due to a pregnancy-specific cause, such as the separation of the placenta from the uterus during normal delivery or prematurely during a miscarriage in pregnancy. Normal pregnancy is also characterized by the tipping of the hemostatic balance to a decidedly prothrombotic state, a change teleologically explained by the need to minimize hemorrhage that may occur during the antepartum, intrapartum, and postpartum phases of pregnancy. The prothrombotic state of pregnancy is multifactorial in origin, arising from, among other mechanisms, increased levels of fibrinogen, certain clotting factors, and von Willebrand's factor, in conjunction with decreased fibrinolytic mechanisms. Other components of Virchow's triad that underlie a prothrombotic state also exist in pregnancy, including venous pooling in the lower extremities and vascular injury as occurs during and after delivery in any pregnancy, and specifically during the more generalized vascular injury that attends hypertensive disorders of pregnancy. This prothrombotic phenotype of pregnancy raises the possibility that the risk of deep vein thrombosis is increased in pregnancy, and as confirmed by numerous studies, this risk is increased manyfold in pregnancy and the puerperium. But what about acute pulmonary embolism, the major complication of deep vein thrombosis? This issue is addressed by El-Gandhi et al. In the current issue of Mayo Clinic Proceedings, using the national inpatient sample to glean and examine pregnancy-related hospitalizations in the United States between the years 2007 and 2015. These authors report that acute pulmonary embolism is relatively uncommon in pregnancy and the puerperium, occurring in 1 in every 5,925 hospitalizations. The occurrence of acute pulmonary embolism imposes, however, striking mortality, the latter increased approximately 200-fold and remaining essentially unchanged over the time frame of the analysis by El-Gandhi et al. Acute pulmonary embolism was associated with such risk factors as maternal age of 35 years or older, Black race, obesity, hypertension, diabetes mellitus, preeclampsia and eclampsia, heart failure, and thrombophilia. An intriguing finding is that the prevalence of such risk factors for acute pulmonary embolism generally increased between 2007 and 2015, but the prevalence of acute pulmonary embolism remained largely unchanged over that time frame. This raises the question whether an increased propensity to acute pulmonary embolism imposed by the increased prevalence of these risk factors is offset by improvements generally in the care of patients during pregnancy and the puerperium over this time frame. Insights in the basis for such strikingly increased mortality caused by acute pulmonary embolism in pregnancy and the puerperium are needed, and as also emphasized by Elgendi et al., the need for novel approaches in preventing, diagnosing, and managing acute pulmonary embolism in these settings. Our first highlight this month is an original article examining why angiotensin-converting enzyme inhibitors and angiotensin receptor blockers are underprescribed in proteinuric chronic kidney disease. It is entitled Barriers to ACE-ARB Use in Proteinuric Chronic Kidney Disease, an Observational Study. It is authored by Dr. Ian McCoy from the University of California in San Francisco, California, and colleagues from Stanford University School of Medicine in Palo Alto, California. Chronic kidney disease tends to be a progressive process and may culminate in end-stage kidney disease. The onset of end-stage kidney disease increases the morbidity and mortality of patients with chronic kidney disease, compromises their lifestyle, and necessitates either dialysis or transplantation. Management of chronic kidney disease includes three main objectives. First, targeting the cause of chronic kidney disease by disease-specific therapies. Second, reducing the adverse consequences of chronic kidney disease. And third, retarding the loss of kidney function with the intent of delaying or avoiding end-stage kidney disease. A major strategy that delays the progression of proteinuric chronic kidney disease is the use of angiotensin-converting enzyme inhibitors and angiotensin receptor blockers, both of which are effective antihypertensive and antiproteinuric agents. Because of such effects, as well as their reductive effect on intraglomerular hydrostatic pressure and their suppressive effect on renal inflammation and fibrosis, these agents are widely recommended in patients with proteinuric chronic kidney disease. However, such use of these agents is not as common as recommended by current guidelines. The present study by McCoy et al. Examines the basis for this disparity between their recommended and their actual use. Employing a single-payer database with patient-level administrative and demographic data, these authors examine current prescriptions for angiotensin-converting enzyme inhibitors and angiotensin receptor blockers on a given date, April 15th, 2017, and prior usage of angiotensin-converting enzyme inhibitors and angiotensin receptor blockers in more than 40,000 adults with proteinuric chronic kidney disease. The data demonstrate that less than one-half of the patient population, namely 49%, had an active prescription on the index date, whereas the majority, namely 87%, were prescribed these agents at some time point prior to this date. Curtailing the use of angiotensin-converting enzyme inhibitors and angiotensin receptor blockers were four main factors: a previous history of either acute kidney injury or hypokalemia, advanced chronic kidney disease stages 4 and 5, and a failure to receive nephrology-based care. Angiotensin-converting enzyme inhibitors and angiotensin receptor blockers may cause a minor increase in serum creatinine because they decrease efferent arteriolar resistance, thereby leading to a fall in intraglomerular pressure and accordingly in glomerular filtration. A modest increase in serum creatinine is generally acceptable, less than 30%, but an increase above this, which is more likely to occur when there is concomitant renal hypoperfusion for whatever reason, may be considered acute kidney injury. However, this ceiling for a permissible rise in serum creatinine has been questioned by some experts as too conservative. Angiotensin-converting enzyme inhibitors and angiotensin receptor blockers induced hyperkalemia reflects diminished levels of aldosterone or decreased levels and/or effects of angiotensin II, the latter representing a major stimulus to aldosterone production by the adrenal cortex. These adverse effects of angiotensin-converting enzyme inhibitors and angiotensin receptor blockers are more pronounced in advanced chronic kidney disease. McCoy et al. Demonstrate that the observed low effects of these agents reflects their discontinuation because of these adverse effects and not because of the failure to initiate their use. Against this backdrop, McCoy appropriately emphasized the efficacy of these agents in retarding the progression of proteinuric chronic kidney disease, and that attempts should be made in enabling their continued use without imposing risk to the patient. In this regard, and in some instances as classified by McCoy et al., these 4 barriers may be considered either modifiable. Specifically, hyperkalemia can be mitigated by a number of approaches and therapies. Nephrology-based care can be introduced, or inappropriate. Specifically, a modest rise in serum creatinine is permissible. These agents may be used in stage 4 and 5 chronic kidney disease with careful monitoring to avoid the risks of elevated levels of serum potassium or acute kidney injury. Resolving any problem usually starts with the identification of its causes. McCoy et al. Are to be commended for the identification of the barriers that limit the use of angiotensin-converting enzyme inhibitors and angiotensin receptor blockers in proteinuric chronic kidney disease, for their delineation of strategies that may circumvent these barriers, and for underscoring that the progression of proteinuric chronic kidney disease may be retarded by the discerning and judicious use of these agents with appropriate monitoring and medical management such that patient safety is always ensured. Our second highlight this month examines non-cardiac surgery and the reduction of cardiac complications. This article, entitled Perioperative Cardiac Risk Reduction in Non-Cardiac Surgery, is authored by Dr. Ravindra Ganesh and colleagues from Mayo Clinic in Rochester, Minnesota. This article represents a contribution to the ongoing series of thematic reviews on perioperative medicine started in the April 2020 issue. In this article, Ganesh et al. Provide a comprehensive review on perioperative cardiac risk reduction in patients undergoing non-cardiac surgery. In the perioperative period surrounding non-cardiac surgery, a number of stressors are imposed on the cardiovascular system, and patients with pre-existing cardiovascular conditions are at an increased risk for myocardial injury and postoperative major adverse cardiac events. Ganesh et al. Begin by broadly discussing strategic approaches in patients with ischemic heart disease, emphasizing the differences in management of patients with either one of its major subtypes, namely an acute coronary syndrome or chronic ischemic heart disease. They then discuss the timing of non-cardiac surgery in patients with a recent myocardial infarction or revascularization, and if revascularization was undertaken, how approaches are specifically geared to either coronary artery bypass grafting or percutaneous coronary intervention. The article addresses strategies that reduce the risk for myocardial injury after non-cardiac surgery, the management of patients with heart failure, either with heart failure with reduced or preserved ejection fraction, that aims to reduce the risk for cardiovascular morbidity and mortality, and concepts and approaches in managing hypertension and arrhythmias in the perioperative period. The final section of the review discusses perioperative cardiovascular medication management, including such medications as agents with antiplatelet activity, non-steroidal anti-inflammatory drugs, aspirin, P2Y12 inhibitors, beta blockers, statins, ACE inhibitors, ARBs, alpha-2 agonists, calcium channel blockers, and diuretics. A helpful table summarizes key aspects of management of the medicines in the perioperative period. This review by Ganesh et al. Has many strengths, including the following: the synthesis of the salient management issues and recommendations pertaining to this topic in one readily accessible article. Clearly enunciated recommendations that incorporate published guidelines from prominent societies that address this topic. The upgrading of these recommendations were relevant based on new evidence that's now available since these society guidelines were published several years ago. The provision of reasoned and prudent recommendations where these societies provide guidelines that substantively differ, and the delineation of areas of uncertainty in this field that are very much in need of further study. You can access these highlights and editor's choice articles free of charge during the entire month of August. When you visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, you will find links to our social media by clicking on the buttons at the top of the home page and at the bottom of any page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, 60 seconds video article synopses, and our Mayo Clinic Proceedings issue summary and Author Insights podcast recordings, which are available from our website on the homepage, as well as through iTunes. You will also find our online-only feature, Pioneers and Legends in Medicine, which are video interviews of people who've made a strong impact in their field of study. You will see many news stories on our websites that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content, such as our Path to Patient image quiz, medical images, stamped vignettes on medical science, and Art at Mayo Clinic features, as well as articles published online ahead of an issue. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.